reporting to soon. Probably you will be putting the patient for a carotid massage, a prolonged Holter monitoring. But yes, if there is a baseline bundle blood block, you might consider anything. Any other views on that, sir? Dr. Karthikeyan, Dr. Thomas may give their views on this.
More than that, here I would like to emphasize one important thing. The clinical history is important. The patient comes to you syncope, this sort of rare entity, even the incident you mentioned, that is very important. The clinical history is suspicion of cardiac syncope in a patient with an IHRS or bundle branch block patient. So every test, we know that limitation. So no, the extended monitoring only helps these patients. Many of these patients we picked up with ILRs, and the clinical history is very strong as a cardiac syncope. And every test has the limitations. The long-term monitoring yields a result. Now we have the access to 1 week, 2 weeks recordings, and we have ILR. So motivating the patients to go for the physicians, treating patients, suspicion for cardiac syncope is the most important thing when they present to you as a syncope. Even though all your clinical parameters or EP studies has the limitations, as you said. So everything has limitations, but suspicion, still you feel that is about how cardiac syncope is a possibility. We need to move on with beyond that investigation to the long-term monitoring. That's what I would like to emphasize.
Yes, sir, perfectly said. So history taking is the most important investigation in a case of syncope. And with that message, we'll move on to the next talk. So Vikrant, is Dr. Prem Kumar's video running now? Can we have the video?
Yeah,
talk. Yeah. Can I try to share this video now? First?
Yes, please.
Okay, can you play the video? Can you play that video? I will give the audio for that video because I'm not able to share from my phone also. The tech team, can you share that video? The audio I can overlap.
Vikrant, can you please play the video? And there was a suggestion in the chat box that you can play with the computer audio on. That might help.
The problem is I don't have the laptop. I have only the.
So, sir, you have already sent the video, probably, Vikrant.
Yes. I have recorded it and sent it. It was actually playing. There is some tech problem. Yeah. At the outset, I'll start the presentation. Okay. At the outset, I'd like to thank the Indian IHRS and Dr. Karthikeyan sir for giving me this opportunity. The topic given to me is evaluation of syncope with bundle branch block, a case-based presentation. I have put some cases of mine and I have used some cases from the literature to explain the point. The first case is he's a 78-year-old man who came with recurrent episodes of vertigo and giddiness. And on deep probing of the history, I found that he had injured his head while falling with momentary loss of consciousness, which he initially denied because from the emergency, they gave beta-vertin hydrochloride and the vertigo complaint completely went off. So patient was very happy. He was about to go home. So when I probed the history very deeply, I found that he had a momentary loss of consciousness because I was very suspicious with the ECG of this patient. Let the ECG come now. The ECG is showing complete left bundle branch block with first degree block. So with this baseline ECG, I would like to think about more the cardiac cause of syncope as the first point than the neurological cause. So I did a Holter for this man for 72 hours. It was very clearly showing complete heart block with a very broad QRS escape actually. And then we requested an electrophysiological study for this gentleman, hoping to find that there will be a very diseased HV interval and infra-Asian conduction system disease for this gentleman. But it was a surprise. This is the EP study of this man. We show for the students, I would like them to concentrate on his bundle pacing electrode. His distal is showing AHV very clearly. You can see the AH is 109 milliseconds, HV is 62. Normal HV is around 35 to 55 milliseconds. It is this 62 is slightly prolonged HV interval. And then when I did incremental ATL pacing for this man, I found that there is AH block, AV vacuum at 360 milliseconds. I let the slide show now. I'm sorry. there was a AH block at incremental atrial pacing at AV ventricular was there at 360 milliseconds, and the VHU was absolutely unaltered during that time. Then yeah, this is the AV ventricular on incremental atrial pacing at 360 milliseconds. And I was pacing from the RA appendage. You can see in the middle, there is a AH block with the arrow is showing, with the HU is still there. So this was a surprise for me. And then I went on to pace more, and at 300 milliseconds cycle length, there was 2:1 AV conduction. With again AH block only was there. HU was unaltered. Can you just slightly fast forward the presentations? Can you just move it slightly in front? So the third or fourth slide. Yeah, this is a 2:1 AV conduction. Can you go to the next slide? Next slide. Just slightly fast. Go in the front. Yeah, I gave atropine for little slightly back. So I gave atropine for this man to stress the AH interval. The AH interval slightly back. Yeah. I gave atropine 0.6 milligram bolus, and the AH interval was still nicely. There was a ERP came down to 280 milliseconds. HU was still unaltered because this patient had a documented complete dot block in the ECG. Then I went ahead with the left bundle area pacing. This patient also had mild LV dysfunction. Go to the next slide. But this patient, what did we learn from this patient is, first thing is, this patient, we have to probe the history a lot in patient like this. Because with amidst the neurological illness, there will be hidden cardiac problem. It would have been life-threatening if this patient would not have undergone the pacemaker. Second thing is, the extended ECG monitoring is beneficial. This patient, on the third day only, this complete heart block is the ECG came out actually. And third thing is, EP study is beneficial if you see a baseline conduction system disease in these patients. If you have, as previous doctor has already mentioned, you cannot do EP study for a patient who is just even having a right bundle branch block alone. I think if there is a baseline conduction system disease with first degree block and all left bundle branch block or a bifascicular block, you will see the EP study will yield a lot. Next thing is this patient, I came out with a negative EP study because except for the HV interval prolongation, EP study is negative because this patient might have undergone a Prochynomet challenge, which is not available with us now. This Prochynomet challenge on HV interval will help to diagnose infiltration conduction disease if available. These slides are already shown by the previous speaker. Can you just move a little forward? Yeah, slightly. Yeah. This is the slide which they have shown on Prochynomet infusion 10 mg per kg for 10 minutes. Initial HV is 70 milliseconds. You can see in a right bundle branch block patient. When you give 1000 milligram Prochynomet, the HV interval is prolonged. It became more than 100 milliseconds. Next slide. So on Prochynomet challenge, if you do incremental atrial pacing, you can see that. Next slide. Yeah. So it was 1:1 conduction with HV prolongation alone. But on pacing in a Prochynomet infusion, you can see that the patient developed 2:3:1 AV block or 2:1 AV block in this patient. Next slide. So I would like to insist upon the EP study in patients with conduction system disease or syncope patients. Anti-arrhythmic drugs should be stopped for at least 5 half-lives to avoid confounding by the medicines. AH and HV interval should be recorded. Antegrade and retrograde ventrivac point should be found. And SNRT about this, Dr. Joy Thomas sir will talk. Antegrade and retrograde ERPs of AV node Hirschsprung system should be found. The standard atrial and ventricular stimulation protocols to find arrhythmias also. Next slide. So now, with the intervals, what did you learn is, in a patient with right bundle branch block, if you do EP study, you measure the HV interval and measure the V to RV apex interval. If you have a normal HV interval and prolonged V to RV apex interval, there is a delay in the right bundle. That means, if you have a normal HV interval and normal V to RV apex interval, and there is a delayed activation of RVOT, then there is delay in more peripheral conduction system. So this type of right bundle branch block, if it is distally blocked, the risk of subsequent AV blocks is little less in these questions. Next slide. Then next step is you have to stress the Isperkin system by atrial pacing, which will provide additional information apart from the basal HV interval. Normally, there won't be second or third degree AV block if you do incremental atrial pacing at rates less than 150 beats per minute. Physiologically, this is due to shortening of the Isperkin system refractoriness during decreased pacing cycle length, or because AV nodal block or happens at shorter pacing cycle length, which will protect the Isperkin system. A second or third degree AV block within the Isperkin system in the absence of changing HV interval, interval, at pacing cycle length of greater than 400 milliseconds is abnormal and it suggests a risk of high risk AV block in these patients. Next patient. Next slide. So Dhingra very long back has told that there will be a greater than 50% progression to high grade AV block if you have a block distal to the S bundle by incremental atrial pacing at less than 150 beats per minute itself. Next slide. I'm sorry for the delay. Yeah, this is important. This is because the basal functional refractive period of AV node usually exceeds the ERP of the Hitchperkin system after the administration of atropine, may be useful in obtaining the ERP of HPS, as atropine has no effect on HPS ERP and shortens the refractive period of AV node. This property of the AV node, the HPS ERP, we can use. This is actually called gap phenomena because the Hitchperkin refractive period is little longer when compared to AV node. This gap phenomena will be exaggerated if you have a infra-Asian conduction system disease. And increasing ERP of Hitchperkin system during a shorter drive cycle length is abnormal and indicates a markedly abnormal Hitchperkin system. Next slide. Yeah. So when Procainamide challenge, the previous speaker already told this. Normal is less than 10 to 20% improvement increase in the HV interval. But if you have doubling of HV interval or the resultant HV interval absolute value is greater than 100 milliseconds, or you see a second or third degree AV block, is infra-Asian block in patients after Procainamide challenge, it is abnormal and they are at high risk for complete AV block. Next slide. So this is in short about electrophysiological studies finding and which are our anomalies. If you have basal HV greater than 55 and the atrial pacing produces HV block less than 150 beats per minute itself, and extrastimulus testing, you see a ERP of HPS greater than 450 milliseconds and increases with decreasing pacing cycle length, and you see a Procainamide challenge with HV interval greater than 100 milliseconds or greater than 100% risk, or second or third degree AV block happens. Next slide. Next slide. Yeah, coming to its case 2, it's a 41-year-old man who had a dyspnea and giddiness. He had a baseline trifascicular block, RVB lady and first degree block. They did a TMT rule out ischemia in this gentleman. They found that, next slide. This is a baseline ECG. It's a trifascicular block very clearly. Next slide. So on doing the treadmill in this man, go back. Slightly go back. I want to see show the ECG during the peak exercise. See at stage 2, this patient little back. At stage 2, this patient developed a high grade AV block on increasing the heart rate. Yeah, not back, little back. Yeah, high grade AV block developed on increasing the heart rate. And patient developed giddiness. When we stopped, it came back to normal. Play. Slightly go to the front. Yeah, this is high grade AV block you see the stage 1 end actually. Next slide. When you after stopping the exercise, it came back to normal. So yeah, next slide. So now what did you learn from this patient is the result of this AV block is probably due to excess-induced ischemia of the conduction system. That is one possibility, but this patient had a normal pulmonary. Second is degenerative disease of the conduction system itself. And then this autonomic imbalance, and then the gap phenomena I told you. So what happened is you have the refractive period of AV node little shorter because the vagal withdrawal is there after exercise, and the exercise will have reduced the ERP of AV node. But the autonomic influence is very less on the Hitchperkin system. It is unaltered, and the gap phenomena increases, particularly in a patient who had an infra-Asian conduction disease. This gap phenomena will be well established. And so the Hitchperkin system's refractive period will be, the gap will be more, which will precipitate a second or third degree AV block. So under this type of patients, you should rule out Leus and Lenegris disease. Both are actually degenerative disorders which occurs with as the patient gets older and older, it can happen. Lenegris disease can sometimes happen with SCN5 mutations in young patient with familial disease also. This both is level and NX disease, they are sclerodegenerative disease on the calcification of the conduction system, which should be ruled out in patients who are having extensive conduction system disease. And these patients will invariably require a pacemaker, particularly in a patient who had a normal coronaries and all. This should be ruled out. Next slide. This patient had a normal coronary. He was not willing for EP study. He had a pacemaker implanted. This is the next case, last case, third case. This case, you can see there is a sinus rhythm with an narrow QRS. There is one broad QRS in right bundle branch block morphology with a little longer PR interval, and another QRS you see in the V6, which is a much more longer PR interval, which produces left bundle branch block morphology. The same ECG, you can see both right bundle branch block conduction, left bundle branch block conduction. This is a classical example of a trifascicular block. Next slide. I've taken one ECG from literature to explain this in very clearly. Next slide. Slightly move forward. Little move. Yeah, this ECG is showing. Can you pause it? Yeah. This ECG is showing very clearly on the left half of the slide, we have right bundle branch block pattern. Right half of the slide has left bundle branch block pattern. You can see the PR interval is around 180 milliseconds, and cycle length of this one is also around 740 something. When the cycle length slightly increases, it produces left bundle branch block pattern around 700 milliseconds, and the PR interval is also more prolonged, around 230 milliseconds it is now. So this is a left bundle branch block and right bundle branch block pattern shown in the same ECG in the same patient. So this is suggestive of an alternating bundle branch block classically. Next slide. So for alternating bundle branch block, you need not have a block in either of the bundles actually. You need to have just a delay in the conduction when compared to other bundle. Right bundle delay in left bundle disease patient, left bundle delay in right bundle disease patient. You just have to delay between the two bundles to produce alternating bundle branch block pattern. And also that you need not have a site of the block at left bundle or right bundle. You can have the site of block at his itself, because his has a predistinct fibers going to right and left bundle. So disease there also can produce alternating bundle branch block pattern. Usually alternating bundle branch block means it's a ominous sign. They have a very diffuse conduction system disease, and they have a very prolonged HV interval. Usually they will be greater than 100 milliseconds. Next slide. Next slide. Next slide. Slightly prolonged. Yeah. So they require a pacemaker definitely, and even if they are asymptomatic, and also they are at high risk for ventricular tachycardia. Particularly, you see in after acute anterval MI, after primary PCI, you see alternating bundle branch block pattern. They have to be under a temporary pacemaker for a little longer time until the recovery. And if there is LV dysfunction, they are also at high risk for ventricular tachycardias. They may need AACD implantation. So this case 4, 36-year-old lady who had recurrent episodes of giddiness and pre-syncope once in a month or less, and one episode of syncope 6 months back. History was like severe exhaustion before syncope, and patient also had a mild CKD 2.5 creatinine. Next slide. So in this patient, I would like to discuss about, her Holter was normal, coronaries were normal. He was not willing for EP study. And then I would like to tell the importance of heart test in this patient, because she had given a history of suggestive of a vasovagal syncope like etiology. First thing. Second thing is, this patient has a syncope which is very, very discrete and very long time duration, like one episode of syncope 6 months back. So these patients will require long-term monitoring of ECG, like implantable loop recorder or something. And this patient also had a CKD in AV block. I will talk about CKD in AV block in the little later slide. Next slide. This is the usual heart response in patients who undergo heart test: vasodepressor syncope, cardio inhibitory syncope, with asystole, without asystole, mixed syncope, and negative test. Next slide. If you have mixed response and vasodepressor response, the patient needs only conservative management, fluid intake, avoid dehydration, normal salt intake, postural training, avoiding vasodilators. If there is a cardio inhibitory response, it is a topic of debate. It will be prudent if the pacing is advised if asystole is greater than 6 seconds in heart test, particularly if used with a closed loop stimulation protocol in pacemaker. Boston provides this. And in a Spain study, they found that greater than 50% reduction in syncope will happen if we have used the CLS pacemaker in 72% of the patients. And if you use regular pacing DDI, you will get only 28% of a, a, a reduction in greater than 50% of syncope. Next slide. we have to stress about the importance of implantable loop recorder in this lady, because initial evaluation of patients with recurrent syncope of unknown cause, particularly very infrequent episodes, ILR is very useful. Particularly those patients who you don't want to put a pacemaker for or in the ICD for primary prevention, who are high risk, who are not undergoing treatment, syncope treatment immediately. You don't want to miss another episode. I think implantable loop recorder is the best investigation. It reduces unnecessary investigations. You keep doing MRI, you keep doing all sorts of evaluations, EEG and all, still you don't find the cause. I think ILR will tell us more. And the current guideline says ILR is class 1 indications for patients who have evidence, the level of evidence A for the patients who undergoes syncope of unknown origin. Next slide. Next slide. Yeah, a little back. The median duration of this ILR will identify the problem in patient is around 7.5 months actually. And then so that is actually a very good duration, because the 3 years is the ILR's time. If you implant ILR until 3 years, the battery will last little later. Yeah. So around 7.5 months it will take for the ILR to identify the problem. There's a median duration. Some people identified early and some people identified late. And there is a it is detected 37. Coming to CKD association. Next slide. Coming to CKD association, greater the degree of renal dysfunction, the higher is the percentage of patients with wide QRS, bifascicular blocks, especially LPVP and advanced wave block. The reason for this is the sclerosis, fibrosis, calcification, the stretch of the muscles, and dilatation of LV. All these things are caused in patients with CKD. You might have seen a lot of CKD patients with normal coronaries. Might have seen in a young age itself they develop first degree AV block and second and third degree AV block. Stop here, please. Yeah, this different types of bifascicular block and the rate of progression of AV block. There is one trial which says that if a patient has bifascicular block with LAHB involvement, there is 35% chances that they will go for AV block. If it's LPHB, 57%. LVB alone, it is 46%. Why left posterior fascicular block has got a more percentages? Next slide. Left posterior fascicle is actually a very resilient structure when compared to other part of the conduction system. Actually, it is the most protected and least vulnerable in left posterior fascicle, and it is short and wide. It is located in inflow. Not much turbulence happens in inflow rather than the outflow, which where the LAF is situated. It has a double blood supply, LAD and PDA. It is not related to structures that are potentially dangerous. It is short and wide and is less vulnerable than thin and longer LAF. So vulnerability is decreasing order is right bundle branch is more vulnerable. Left ventral vesicle is little lesser than this one, and the left posterior vesicle is little lesser, and left bundle is the least vulnerable. Next slide. Next slide. So if you see a back a little back. So if you see a left posterior vesicle block in a right bundle branch block, that means a protected structure is damaged. Means then other structures are already damaged. That is what it means. So when the conduction system lesions are so extensive that they alter conduction in the posterior vesicle, it is nearly axiomatic that the right bundle, anterior division left bundle, or both are also already involved. So that is why a posterior vesicular block is there, means along with the right bundle block, there is extensive damage to the conduction system. They have higher incidence to go for AV block. Next slide. So this patient had a negative heart test and so on a conservative management. So thank you for patient listening. Yeah, you can stop the presentation. I'm sorry for the inconvenience.
No, sir, it was actually not your mistake because you had already forwarded a recorded presentation and it just didn't work out on the technical team, and probably you did great to do an impromptu audio cover, because very good at your part. So great presentation, sir, that we were able to discuss 4 PVC cases. Just a couple of quick questions. First is that in today's date, when we have AHA and ESC recommendations that when we have a bundle branch block with unexplained syncope, and so we can unexplained syncope after non-invasive evaluation, that we can implant a pacemaker directly rather than just going for an EPS or other invasive investigation first, because it's a class 2A recommendation now. And in 2022, we had 2 trials, one in JACC-EP and one in heart rhythm. Both were randomized, which showed that a pacemaker versus ILR, when they are compared in these group of patients, so pacemaker might reduce the risk of recurrent syncope, although not giving any more mortality benefit. So, what are your comments on that?
I still stick on to identifying the cause of the problem in this patient. Particularly now that the long-term monitoring is available, like 2 weeks and all, you can monitor the ECGs and then implant a loop recorder. These type of things should be taken care of. Actually, I already told you, patients who are having syncope, but the cause is not identified, who are at high risk. If you think this implantable loop recorder will help definitely in this patient, and particularly low risk in the younger age patients and all, I think the HUD test has to be made use more to identify the vasovagal syncope problem. Because after implanting pacemaker for a syncope of undetermined origin, if there is a vasodepressor type and neurocardiogenic syncope, the patient won't get definitely benefited in those patients.
My specific question was, so when we are considering an ILR implant, so ILR being an invasive procedure and a significant cost involved, so should we consider a pacemaker directly rather than an ILR, because it will treat and as well as monitor, and because there have been recent studies which shows that pacemaker may be more beneficial because it significantly reduces the risk of recurrent syncope.
Yes, sir. But you are asking in a bundle branch block patients or in a patient who has got a bifascicular block, just this one and all.
So if a patient has a biofascicular block and has an unexplained syncope, and you have exhausted all your non-invasive investigations and you are still not there with an answer about the cause of the syncope, so do you implant an ILR or a pacemaker?
I will still go for ILR, although the studies say I will still resort to ILR, because pacemaker again it's a transvenous lead. It is a moribund for a patient. So I will definitely implant ILR, which is actually a very I will say it is actually a very non-invasive procedure. It is a OP procedure and it can be retrieved easily after 3 years. And if the patient problem is diagnosed, then you can remove it immediately. And it provides a very long-term support. I will still resort to implantable loop recorder rather than putting a pacemaker on these patients.
CPS before any invasive procedure in all cases? Yes.
No, invasive, of course, I will definitely do electrophysiological study in those patients before implanting ILR, because I will exhaust this invasive investigations also.
I think it's very important. Raghav's question is very important in real practice life. The patient with the bundle branch block, especially bifascicular block, come to us with the syncope. Again, it's very important, as I mentioned already, history taking is very important. That is a cardiac syncope. Okay, there is no any sign suggestive of vasovagal or neurocardiogenic syncope. And it's very difficult for the patient to convince them for what he is asking ILR, what you are suggesting. ILR is very expensive now. The current ILR, which they removed the simple thing also now, that injectable ILR is costing about 2 lakhs rupees to the more than that. So it is very expensive for the patients to afford it. So whether we can take the patient directly when you are convinced from the history. Again, the history is very important. We can at the most ELRs are available for 1 or 2 weeks recording. But still, if you are not able to document that thing, so what is that? Better to move on to the EP study. So sometimes on table you can do an EP study. So many times we record the Hisbundle HHV interval, some provocation test, and then we can proceed on the same sitting with the pacemaker. The patient LV function is normal and the LV dysfunction is there. Road inducible VT AP has become must. The LV function is normal. When the clinical history is here, I feel is very important. The patient comes with a lot of MRIs and CTs and EEG reports and other things. At the most, they will have only one Holter. Most of the centers are not doing ELR. Doing ELR is very important. As you mentioned, that looking for the carefully that the demonstration of alternating bundle branch block. Unless you go through the Holter very carefully, then only you can pick it up. The technician takes few pages of printout and pass on to you, then you report it. So it's not so you have to go through the recordings properly, recognize the alternative branch block, go through all the patient serials of ECGs. Is there any alternative bundle branch blocks are there? Those things are very important. But in reality, clinical history, and based on that, you can implant a pacemaker. I would fully agree with Raghav Bansal, because convincing patient with the economically patient, very difficult. But you have to be very sure that that the history taking is very important. That needs experience, and so when you see every day, so practically, so in our hospital we see 30 to 40 patients a month. So syncope, we know that who is having cardiac. So what extent you can go for it. But look at the patient economic also. So we can't tell very expensive things. So at the same time, you are so convinced we can put them on a pacemaker. When, so that's what I personally is my personal opinion. I think Raghav will.
Yes, sir, I completely agree with you. And sir, along with the history taking, which is the most important tenet of the evaluation in these cases, we should also have a close look at the ECG. And ECG often provides very useful clues, like if you have absence of S waves in one AVL or B5, B6 in the presence of right bundle branch block, you might be actually dealing with a right bundle branch block plus a left bundle delay, which is called as a masquerading bundle branch block. And these subsets are a higher risk, and you might lower your threshold for implanting a pacemaker directly. So great talk and great discussions of probably in the interest of time, since we are running short of time, let's move on to the next talk. So going to the next
thank you very
talk,
much. Thank you very much.
I would like to invite Professor Joy Thomas for this next talk.
Are you able to see the screen?
Yes, sir. Good. Go ahead, sir.
Yes,
Can you hear me?
Yeah.
Okay. Yeah, my brief is to talk about pacing for sinus node dysfunction. When do I do? That is, in other words, indications. All of you have to excuse me because I've been having a bad throat the last few days, and I may be coughing a lot. And so I purposely made this talk a little short. So I hope it will be short and sweet. Okay, the sinus node is a structure which is located at the junction of the superior vena cava and the right atrial appendage as an elongated structure, as you can see here. And just a minute, I'll get the laser pointer. So as you can see here, it's an elongated structure. And in this cartoon, you can clearly see that this elongated structure is elongated almost vertically. And the red colored portion is the actual sinus node, whereas the yellow portion is the peripheral pacemaking tissue. And this white spot refers to the dot is a place where the actual pacemaking tissue is located. This is in fact the histological view of it. You can see here the sinus node artery in the middle of the sinus node, and then you have got the musculature that is of the superior vena cava here, and the atrial muscle, that is the crista terminalis, located here, and then you have got the venous valve located in this point, and this is the epicardium, this is the endocardial surface, and you have got the subepicardial tissue and fat here, and this portion is the uh, uh, part of the auricular muscle. So this is the atrial muscle, and this is the crista terminalis with the pectinate muscles located here. So what are the conditions that cause symptomatic bradycardia in fixed sinus node disease? One is the autonomic influences. You must not forget that the autonomic nervous system innervates the sinus node, so that anything that causes from the central nervous system, for example, fear of fright, can cause an increase in the heart rate through the sinus node acceleration. Similarly, fear and also some of the emotional responses like extreme agony from visceral pain, etc., can cause slowing of the heart rate from, again, parasympathetic influences that affect the sinus node. So this is a very important part of bradycardia. One should never forget. A lot of it has been discussed earlier by the other speakers in various on various topics. Then, of course, comes ischemic. The sinus node artery can get affected when there is a block of the corresponding coronary artery that supplies the branch to the sinus node, and this can cause bradycardia during the event of an acute myocardial infarction or even in chronic ischemic heart disease. Then, of course, you have got degenerative heart disease, the degenerative disease that is in general a part of the aging process of an individual. just as you have arthritis in the patient, these patients can have degenerative disorders that affect not only every part of the heart, but of the body, but the heart as well, and they can go in for degenerative sinus node disease. A bit of a functional thing is the atrial tachycardia. The atrial tachycardias, which can come in the form of paroxysmal atrial fibrillation or ectopic atrial tachycardia. These atrial impulses that arises from an ectopic focus can enter the sinus node and discharge the sinus node so that it gets reset each time an external atrial impulse enters the sinus node, and preventing the sinus node itself from giving its pacemaker impulse. And this can cause a very long bradycardia episode of sinus pause, which can lead to a sinus arrest. And of course, you have got drugs and toxins. Some of the drugs, which we commonly use, like beta blockers, digoxin, and amiodarone, not to be forgotten, can cause severe bradycardia if they are used in excess, particularly when they are used in combination. A combination of amiodarone and digoxin and beta blockers, if used in a heart failure patient, can lead to dangerous levels of bradycardia. And then toxins can come from various insect bites, or even from like scorpion stings, and also from toxins which are consumed for the intent of suicide by some of the patients. For example, things like crotalaria, etc. So looking at the sinus node and its arterial supply, you can see here the circumflex artery, and a branch from it loops up to provide a branch to the sinus node, which is located here. And here in this, that you can see how the right coronary artery gives a branch to the sinus node through this loop, and also from the left the left circumflex artery can give a branch to the sinus node. So in other words, it's not only the right coronary artery, the circumflex artery also can be a source of supply to the sinus node. If both of them are supplying, that is the circumflex artery and the right coronary artery, then the chances of having an ischemic insult to the sinus node is much lesser. Having said that, let us look at the percentage-wise. The right anterior sinus node arteries of glucose is seen in 64% of the patients, the left anterior atrial artery in 22%, and left atrial artery in 2%, and a left lateral atrial artery in 8%. So this is from a study by Yan Ho in 2013. Now, coming to one of the cases that we see, that I saw in the emergency, this is a patient who had occluded, right? You can see here, this is the patient come with MI with an occluded artery. And this is, you can see, is the sinus node artery, which is coming around upwards. And there you can see that there is some decreased flow here in the blocked vessel. Patient had come with arrhythmia, bradycardia. So temporary pacing lead can be seen, which is making sure that the, making sure that you have an adequate rate. And subsequently, after the angioplasty, the rate had improved, and the patient had now had a better rate. I wanted to play this again, but okay, it's not going. We'll go to the next. So this is in effect a patient cause for ischemia, acute MI, causing bradycardia in this patient. Now, to discuss about this case, in this particular patient, the very next day, the patient's arrhythmia and the bradycardia had all disappeared. We could, after 24 hours of observation, remove the pacing wire, that is the pacing lead, because we saw that the patient had adequate rate and rhythm in the CCU. and he could be discharged in 3-4 days without a pacemaker and temporary after 24 hours. But in some cases, you can see that you will note that there will be persistence of this bradycardia because the artery to the sinus node might have got totally occluded. And in such cases, you may have to have a permanent pacemaker. Now, the question is, how long do we wait? Do we wait for 2 days, 3 days, 4 days, 5 days before we? According to latest reports, the duration is 4 to 5 days. So, if after 5 days you still need a temporary to maintain an adequate rate in this patient, and this patient are having sinus node dysfunction from the blocked sinus node artery, then they would be better to provide a permanent pacemaker in this patient. Now, going to the next case, this is a 44-year-old male came with giddiness. You can see this ECG has got some interesting findings, but what is very relevant to this patient with giddiness and a few syncopal episodes as well is the long pauses that is found between the some of the QRS. Of course, he has got not only sinus pause, he has got retrograde P waves, and you can see this retrograde P waves behave in a Wenckebach-like fashion, and then this last P wave even causes a re-entry ventricular beat. With all this ECG peculiarities in this patient, what is important, most important to us, and what we have to do for the patient is we have to relieve his symptom. This is remember, this is a 44-year-old male working member, and giddiness can upset his work. In fact, this gentleman was working as an accountant, and he said sometimes during his board meetings he was felt very tired. He may be even dozing off, and that was affecting his work. So, with all these problems and definite history of giddiness, there's no doubt. There was no doubt in my mind that this man required a permanent pacemaker. Do I do a EP study in this case? I never offered an EP study. I thought it's quite evident that with a symptomatic man with bradycardia and of this type, certainly requires a pacemaker and no further investigation. So he had a dual chamber pacemaker. Now, speaking about dual chamber pacemaker in this type of people who have got good AV conduction, as you can see here, the AV conduction after this re-entry breath, the PR interval is very short. And one can do an EP study just to find out the robustness of this AV conduction and then decide whether one would pace the atrium alone in this patient, because that is what is needed. Once you pace the atrium, he would have a good rate and a good AV conduction. With a good AV conduction, he should not have a problem. So we can maintain a nearly physiological type of condition in this type of patient. Now here's an 80-year-old lady, hypertensive lady, diabetic as well, who came with bradycardia, and she did not have any giddiness or any symptoms of syncope. But what I found was that in an echo, unfortunately, I don't have the echo pictures with me. In fact, let me confess that this is a picture I have taken from the internet. And so there was this lady who had this bradycardia, and the echo shows a little dilatation of the atria as well as the ventricle. The EF was still around 50%. So in this 80-year-old lady, the creatinine had gone up, that breached the upper level, and it had gone up to the upper level was 1.2 in the lab, but it had gone to about 1.4. So with just bradycardia, without frank syncope, but she had fatigue, I decided to do a pacemaker, put in a permanent pacemaker for this patient. Now, what sort of pacemaker is needed? As you can see here, it's only sinus bradycardia. The PR intervals are normal. And the QRS is absolutely narrow with a normal trend from is in V1 This shows only the limb leads and V1. We don't have the V3, V4, V5, 6. But if you see that the QRS is normal all through from V1 to V6 without any bundle branch pattern of a right bundle or a left bundle, and with a very short PR interval, uh, atrial pacing would be ideal for such patient, because we will get rid of the bradycardia and make sure that the patient has a physiological type of atrial pacing and ventricular sensing. And this will also help us help the patient we will be helping the patient to prevent any LV dysfunction in future. So then coming to the another case, this is a 65-year-old businessman with recurrent attacks of pre-syncope and 2 episodes of syncope. Now, this was, in fact, when Prem and others were discussing about ILR, I wanted to jump in and talk about this. But then I thought, anyway, I'm discussing this in my talk, so I'll hold it for that. Now, this was a gentleman belonging to the North Indian community who works in Chennai, has a business, financial business, let's say, in a rough word. Recurrent attacks of pre-syncope and 2 episodes of syncope. In his initial investigation, the ECG was normal. His echo EF was about 63%. He had a good left ventricular systolic function, grade 1 left ventricular diastolic dysfunction. He did not have any regional wall motion abnormality. In his history, he had no angina as well. And at that point of time, because of his episode, he had only, when he first saw me, he had only 1 episode of syncope. So I suggested to him that he might require a pacemaker. So he was against a pacemaker. He said, why pacemaker? मुझे एक ही बार हुआ है, so why should I go for a pacemaker? I tried to explain to him in different ways how it could prevent injury, how it could prevent including a fatal episode, how it could be fatal because if he was outside on the road or somewhere driving, etc., etc. Whatever we could say, he was stonewalling me to say, Doctor साहब आपने मुझे दवाई दो. So I yeah, had to make sure that he was not on beta blockers or something, and in fact changed one of his drugs to amlodipine so that to keep his heart rate a little high. And anyway, he had I advised for the ILR. Then I told him, okay, you put in an ILR. Dr. Prem was talking about ILR, and Dr. Yadav was telling that why not go for a pacemaker and the thing. See, sometimes when we advise for a pacemaker, the patients do not want a device permanently inside. They just want to get around it. That in such situations, an ILR can be done. And I advised ILR. He still did not do, but again he had another episode, and this time he was willing and he underwent the ILR. So first checkup after 3 months, this gentleman came. There was nothing in the, he said, no syncope, nothing, no episode. I did the interrogation. It was a Medtronic one, Reveal Plus, I think. And nothing was forthcoming from that. And then after his first visit, that is, which was after 3 months, when he came, he had a long episode of syncope, and that corresponded with a long sinus pause. Now, this time he was convinced, and finally we put in a pacemaker. So ILR has its uses, particularly for convincing patients who are very reluctant to put a pacemaker. Not everybody is willing to immediately accept the implant of a pacemaker the moment we advise them. In such people, ILRs are very useful. And of course, if the symptoms are few and far between. So this is again, I have taken from the internet just to highlight how the sinus rhythm patient goes to bradycardia, like what you mentioned earlier. It could be vaguely mediated, and then the thing gradually recovers. Which again, here you can see that again there is a tachycardia which is going on, and suddenly the patient goes in for a bradycardic episode, which is symptomatic. What is other important is paroxysmal atrial fibrillation, like you see here. This atrial fibrillation episode can also cause bradycardia and syncope. And this can be particularly seen in people who are elderly and who have these episodes of giddiness or faintness, but do not know anything else. Even the atrial fibrillation may not be evident on a clinical ECG, but Holter may reveal small episodes of fast atrial runs or tachycardia, or even short run of atrial fibrillation. Nowadays, of course, we have got the Apple Watch and the other watches which do, some of them do give us information. So those may be helpful apart from a Holter in giving information about this. My brief is about when do I do pacemaker. So that is what we have been discussing, and that's what I try to discuss with these cases. But in an electrophysiology study, as you all know, the sign you have got various zones. When once you start pacing the atrium, uh, uh, these atrial impulses enter the sinus node, and they modify the sinus node in various ways. The initial thing is when you have a small decrement between the sinus cycle, the first thing that happens is a collision. That is, the atrial impulse enters the sinus node. The sinus node impulse is about to come out, and both of them collide so that the atrial impulse overcomes and captures the ventricle. The next zone that, as you reduce the cycle length of pacing lesser and lesser, you have the zone of reset. In zone of reset, what happens is your atrial impulse has captured the atrium, the impulse has traveled into the sinus node. The sinus node impulse has still not formed, but this particular impulse resets the sinus node, and the new sinus cycle timing starts. So that is the zone of reset. And if you still further reduce the cycle length, then you have the zone of interpolation when there is a capture of the atrium and the sinus node enters the sinus node, and then you have got an impulse that also would have come from the sinus node later, and that causes the third impulse. So this is the zone of interpolation where two impulses from one from the what you have paced and one from the sinus node, which has already recovered and given an impulse. And then, of course, there is the zone of re-entry. So these are the four types of responses that can happen when one paces the atrium, and this has to be remembered during your EP study. All of you must be quite familiar with the tests of sinus node function. These are not great rocket science, and sinus node recovery time is the thing is the used to be in vogue some years back, and it used to be the gospel thing that you do the sinus node recovery time. The corrector node sinus recovery time is greater than 550 or 600. You put in a pacemaker. So what we do is we do a pacing, and the time taken by sinus rhythm to resume after period of overdrive atrial pacing, usually for 30 seconds, and it is defined as the interval measured in the high right atrium lead from the last pace complex to the first spontaneous complex after cessation of pacing. So we do it at several cycle lengths, and the longest values are taken. The normal is uncorrected is less than 1500. Corrected normal is less than 550 milliseconds. So this used to be the thing, but currently we don't use it. Here is one example of sinus node recovery time being done. So the atrial impulses are then you start pacing at a cycle of length of say 700, and then you stop, and then you see that this is the sinus node recovery time. So 1175. So what we do is the cycle length, the coronary cycle length is 930, that is the normal cycle length, 930. The paced cycle length is 700, and what you get is SNRT, sinus node recovery time, is 1175. So the corrected sinus node recovery time is 245. So what has been subtracted from here is not 700, but 930. So this becomes the corrected sinus node recovery time. So one has to, prior to starting the thing, measure the interval between the normal spontaneous cycle length. Note it down and then start the pacing. And once the pacing is done, the corrected sinus node recovery time is done by this recovery time minus the original cycle length. This is taken from a handbook of cardiac electrophysiology. I would recommend you guys to read it. It's a very useful one. I'm sorry, this one. So sinoatrial conduction, what is sinoatrial conduction time? That's the time of the taken by the impulse, which is generated within the sinus node to come out of the sinus node and activate. So this is the sinus node, the time taken for it to come out, and the peripheral zone of the sinus, and then activate the. So the moment it enters the sinus node, from the sinus node to the atria, the time taken, that is the conduction, sinoatrial conduction time. How do we measure it? So if you look at this interval, this is the normal sinus rhythm. The sinus impulse has come out, captured the atrium. This A is the atrium. So you have A1. The next cycle comes out and atrium. So A1, A1. So this is the normal sinus cycle length. Now you give a pacing impulse here, that is A2. That pacing impulse captures the atrium and then it enters the sinus node. So it is conduction time in. That means it is going into the sinus node. Once enter the sinus node, the sinus senses it, and then what happens is it enters in, and once the sinus node senses your impulse, which has come from the atrium, its timing cycle gets reset. So when the timing cycle is reset, this cycle once again starts, just like your alarm clock. So it starts, and once the time has come, again it comes out. So this particular time, that is the CT in and CT out, in your thing, if CT in is equal to CT out, and if sinus cycle length is constant, then two of these conduction time is equal to A2 minus A3. So this is the concept of sinus cycle length. So just divide this thing by 2 and you get sinoatrial conduction time. This is more of an academic exercise. I don't think hardly anybody is interested in doing these things.
Dr. Jai, can you wrap it up? It is time.
Yeah, I've come to the last few slides. So we have sinus bradycardia, sinus pause, sinus arrest, sinus node exit block. As you can see, sinus arrest, sinus exit block, tachycardia, bradycardia. So these are the various forms of sinus node recovery time. So coming to the thing, this is a 2017 indication. Symptoms directly attributable to increase heart rate and improve symptoms. Mind you, symptom is the word in the class 1 indication. In patients who have, again, symptomatic sinus bradycardia. So remember, in any of your patients, the symptoms is the key word in this patient, not the ECG, not the thing. If a patient has any symptom, one has to, again here, you see it is symptoms, symptomatic, symptoms. So it is symptoms we should go by. This is the 2021 basic for bradycardia, tachycardia form, enabled pharmacological treatment. Indicated patient with atrial arrhythmia, mainly AF and permanent drop-off, irrespective of symptoms. This is quite important. And permanent drop-off. Sinus node or dual chamber pacemaker, minimization of ventricular pacing through programming is recommended. 1A. So one should program the pacemaker so that you get maximum pacing. So that's why I kept mentioning that one should aim for atrial pacing as much as possible and minimize ventricular pacing. Dual chamber cardiac pacing is indicated to reduce recurrent syncope. Patient expert with the severe unpredictable who have spontaneous documented symptomatic age more than 3 seconds or asymptomatic pauses more than 6 seconds. Mind you, this is a 2021 guidelines from European Society due to sinus. So even if a patient is asymptomatic, if they have pauses greater than 6 seconds due to sinus error or AV block, one can do a pacemaker. It's a 1A indication. Cardio-inhibitory carotid sinus syndrome. This is why I asked Balaji this question. But he clearly mentioned it's for children that these things are. But here we are dealing with adult cardiology. Asystolic syncope during TIL testing. So 1A indication. So with the take-home message is where AV conduction is robust, atrial pacing provides almost physiological chronotropic insufficiency exists. Rate response is needed in your pacemaker. Avoid unnecessary ventricular pacing. Where there is LV dysfunction, CRT or conduction system done. Strive for optimum setting and follow-up to enrich the patient's life. Value of EP studies is not very robust in patients with sinus. Symptoms remain the cornerstone of the need by patient. Thank you for your patient listening, and sorry for taking an extra minute or two.
Thanks,
Thank
Dr.
you.
Jai, for the excellent talk overview of sinus node dysfunction and when to intervene. So, for the benefit of the students, I would like to ask two questions, important questions. Till all the Holter reports gives the value of pause more than 2 seconds. How many times patient has had a pause more than 2 seconds? This has been imprinted by them, all the many people, physicians. Any pause more than 2 seconds is alarming, and immediately recommend the pacemaker to go for a pacemaker, irrespective of their symptoms. Many times it will be instantly detected or anything. What is the opinion on that? And then others have
I just gave my last slide, almost the last segment, gave that answer. 2021 European Society Cardiology says in asymptomatic patient, more than 6 seconds, you can put in a pacemaker. And in symptomatic patients,
that is the important message. And OSA, obstructive sleep apnea. Can you any comment on OSA, evaluation of OSA in these patients, any past patients?
Evaluation of OSA is quite important. Of course, I didn't touch upon that because I was concentrating more on pacemaker. Because they are both linked, obesity, obstructive sleep apnea, and hypercarbia. All these can cause respiratory acidosis and then bradycardia. So evaluating the patient for that and giving them a trial of CPAP is very, very important. Once you see that there is a significant amount of apneic spells in these patients. And Karthikeyan, thank you for bringing up this topic. And this is a disease which is there in our population. And particularly, you look around us, you find a lot of obese people going around. And definitely, it's a wonderful, something which we have to look into.
Someone is not affordable for so you recommended atrial based pacing is very important in this patient once you decide to go for a pacemaker. So someone is when do you recommend only AIR pacemaker? A lot of limitations are there in a patient cannot afford for dual chamber. So what test do you perform on table to decide whether the patient is sufficient enough to put only atrial based pacing alone?
When I have a patient of purely sick sinus syndrome, I know the AV node is normal. I make sure I do an EP study and see that the AV conduction is quite robust. Do all the maneuvers, pace up to 160. They say 140 is enough, but I make sure I go up to 160 at least. Look at the HV interval characteristics, look at other things. Pace the ventricle also to see if there can be something else that can create these problems. Because I think was it the paroxysmal atrial standstill what we heard today about even ventricular or atrial things which can induce that. So always pace the ventricle also when you do these EP studies to make. Once I'm convinced about it, I do atrial pacing. I've done a number of atrial pacing and they're all doing quite.
The very important message here is even if you put a dual chamber pacemaker in this patient, then a sinus node dysfunction patient, programming is very, very important. Not leave it to the technical person. So just because
programming is the most important thing.
Pace all the time, both the atrium and ventricles are paced 100% pace, V pace. That should not happen because allow the program. There are options are available to the different vendors like managed ventricular pacing or AV surge, stress. So many things are available to not to pace the ventricle so that the pacing induced cardiomyopathy can be avoided. Atrial based pacing alone is sufficient. Ventricularly, it can be a backup this thing whenever is required. So that is very, very important that commonly we see that patients are getting a dual chamber, but all the time paced both the chambers. So that is should be avoided. And other important aspect of atrial based pacing is importance of atrial. Why not go for a single chamber pacemaker in this patient, ventricular based pacemakers? The incidence of atrial fibrillation, would like to comment on this. Why this physiological pacing of atrial based pacing is more important in this category of patients?
You're talking about sinus node dysfunction patient?
Yeah, sinus node dysfunction patient,
Yeah. So sinus node dysfunction patient, I would, straight away prefer the atrial pacing. If VBI pacing, I would rather not do in these patients because the chances of their atrial condition worsening is more. And the chances of pacemaker dysfunction and patient having symptoms of thing and going in for atrial fibrillation and other thing in the long run is much more. So if I'm doing pacemaker, I will tell them either you have a single chamber atrium, provided I'm sure that the AV node is fine, or if I insist of single ventricle, no, I will always do a dual chamber one, never a single ventricle.
Raghav, anything you would like to add?
Yes, sir. So before sir, we wrap this excellent session up, so I have a couple of quick questions from Dr. Thomas's talk. So first is regarding that 44-year-old male case which he showed, who had very long sinus pauses. So it's very uncommon to have such a sinus node degeneration at the age of 44. So what evaluation would you like to do before implanting a pacemaker in such a case? That is my first question. And my second question is regarding the other case, the 65-year-old male who underwent a ILR implantation before a pacemaker. So since the person was not having a significant sinus bradycardia or exercise-related sinus problems, so can it be just a vasovagal syncope which happened after 3-4 months, and the ILR just detected a cardio-inhibitory vasovagal syncope rather than a sinus nodus on this one?
That is not cardio-inhibitory. He had a pause. The cause might have been cardio-inhibitory, whatever, but he had a long pause. This man had fallen down. He was unconscious for a few minutes. And yet, in all these cases, I told you, he was very, very reluctant to have a pacemaker. In fact, after his first episode of syncope itself, I told him better to put a pacemaker. At that time, I did not have much thing that I told him, okay, do a Holter. Holter was negative, normal. Everything was normal because he was having between his first syncope and second syncope, the interval was more than 6 months. Thing. After he had the the second syncope, then he agreed to do the ILR only. He still didn't agree for the pacemaker. After the second syncope, we put the ILR. The ILR, after about 4 months, first visit, I told him to come after 3 months. Nothing happened. Nothing was there. The fourth month, clearly it was there. It was a long pause. If I remember, it was about 2 to 3 minutes, the long pause. And then somebody did a massage and something like that, and he recovered. All the thing was clearly documented. I have those things in my thing somewhere, but over the years, I've changed my laptop so many times. I'm not so very, what do you say?
His first question was
As you guys.
particular male.
Yeah.
The other question.
But it was that. Regarding the first question, all I wanted to know, this man was a young man. Like I told you, he was accountant, and he used to travel around the country and all that. So I did not do much in this. Regarding the cause for that, I went into his history whether he is taking any substances. That is, some of them have this kine and so many other things. In detail, I asked him. He said there was nothing of that sort. The only thing is he used to have some liquor once in a way. That too, maybe 3 times or 4 times a year. Beyond that, there was nothing. As far as angiogram is concerned for ruling out ischemic sinus node disease, I did a treadmill, but the treadmill was negative. Therefore, I did not do an angiogram.
So the growing evidence of amyloidosis, when did you consider amyloid presenting as a cardiac amyloid presenting as a sinus node dysfunction?
His echo was normal, and there was clearly no spectrals or something to indicate cardiac amyloidosis. I did not check for amyloidosis because everything was looking normal.
Or probably an inflammatory cardiomyopathy, or which might present with a sinus node problem, or
something like a myocarditis, you're saying? Myocarditis or sarcoidosis or things like that. Those are things I did not check for actually. In retrospect, I should have checked for that more thing, but I was more interested in the symptoms and relief. And unfortunately, I changed hospitals, so I don't have follow-up of the patient anymore. Otherwise, what Raghav just told, it's very important to know what these things are, and I could follow it up.
One last question from the chat box. When will you suggest to do an EPS in a suspected case of thick sinus syndrome?
Can you repeat that?
When will you suggest to do an EP study in a case of suspected thick sinus syndrome?
Thick sinus syndrome.
Yeah. So in a suspected case of thick sinus syndrome,
okay.
When do you do an EP study?
Okay. So when you don't have any ECG evidence, Holter evidence or anything, first do the non-invasive studies and other things. I will do a HUT study also, a head-up tilt table test and all these things. And if all these things are negative and not for and a diagnosis is not forthcoming, then I will ask for an EP study. And before doing an EP study for any patient with the for bradycardia study, I always tell them EP study is only forthcoming. The result will come only in about 35 to 40% of the time. Rest of the time, we will not know, come to a decision. So that is very important to tell the patient and then do this.
Okay,
And
thank you.
we also have to tell them that if this is not forthcoming, the next will be an ILR.
Yeah, so it's a very
Okay.
important message, So it's a when to consider EP study and when to consider ILR, and many decisions are clinical based. That's very, very important. The patient who had a syncope, syncope history
Absolutely.
evaluation is important. Everything, this entire topic of today's discussion added on to the when the patient present to us with the pre-syncope or syncope, how much we are convinced about the cardiac origin. Many times in practical, we see that the patients are just done on Holter and send them back to the neurologist and end up taking antiepileptic medication. Then they come to the emergency room on another day with the worsening of bradycardia. And how many of them we are losing them. They are not able to reach the hospital. We don't know that because cardiac syncope has a very high mortality. So one should not miss it. The clinical suspicion is very, very important. Every available investigation has the limitations. We cannot do ILR like abroad. They are doing routinely when we visit any lab in Europe and US every day, 3-4 patients are posted for ILR implants. We are even a year also we are not able to do in India that many ILRs. So because of the cost constraints. So the clinical suspicion is very, very important in a syncope evaluation in a patients of whether a congenital alveolar block or bundle branch block or a suspected sinus node dysfunction. All the more the paroxysmal AV block, all those things narrow down to clinical evaluation of syncope or pre-syncope and what extent we can investigate it. And then instead of putting the ball in the neurologist court, because in our country, the many patients after losing conscious, they are the first man to land is the neurologist. The physician also refers the patient themselves go to the neurologist. So they get
And they are on anti-seizure drugs.
Yeah, they're on anti-seizure drugs, So when we have seen patients taking 2 or 3 anti-epileptic drugs because thinking that is a refractory epilepsy or anything, and then finally land to the emergency, the complete heart block or whatever, then ended up stopping all the medication after pacemaker. So, yeah,
one thing. Yeah, regarding the cost of ILR, see that patient whom I put the ILR, Medtronic were very considerate. What they did is they reduce the cost of the ILR from the actual pacemaker which I implanted later on.
So
So
that
they gave that benefit.
yeah, that was there.
That benefit they gave the patient.
Yeah, that was there till the Reveal XT was there. Now you know that Reveal XT has been withdrawn from the market. No longer Reveal is available, which was at least we could able to convince few patients when it was there. It was only 50,000-60,000 rupees. Now the only injectables are available, Reveal Link and so on, corresponding to the other companies. Anywhere between 1.5 to 1.75 lakhs is the cost of any of these injectables. Nothing less than that you will get it. That other cost to that to the things you will not implant this below 2 lakhs rupees. Impossible for any hospital to implant this implantable. So 2 lakhs is not an ordinary budget for our population. Even I am not sure that even insurance will cover that. These are all practical limitation. We face this problem. We see a lot of patients. We recommend them, but how many of them take them for the things? Current situation is challenging. That boils down to the clinical, utility of our knowledge and how to narrow down when to go for, as Raghav rightly put it, there are looking at other things, so carefully looking at the ECGs, again going back to the clinical history, elaborate clinical history. And when we can do that in an ideal patient, the empirical pacemaker or simply do an EP study. The students, for the benefit of the students, utility of the EP study is very, very important in these certain patients, especially the bundle branch block and pacemaker patients. And the other important thing is heart test. Heart test, as Joy mentioned, the syncope with the documented sinus or asystole is much more valid than the heart-induced asystoles. The studies has already shown that heart-induced tilt table may not able to reproducible in a real-life manner. But if you record it on the ILR and the real things, it's very much more valid that those patients are getting maximum benefit out of pacemakers. So that should be remember that. And I hope this today's talk could have benefited every student and practicing physician and cardiologist. Dr. Vijay Shekhar excellently presented with this paroxysmal AV block. This is very, very important. Again, it is a clinical suspicion and long-term monitoring gives the answer for these things. So I would like to thank everyone, all the faculties, and for their excellent contribution to this today's talk. And thank Dr. Raghav and for his contribution, and all the attendees who have benefited. This talk is going to be recorded version is going to be available in IHRS website in soon. And those who missed the opportunity to attend this session can later review it and get benefit out of it. Thank you very much.
I would like to thank Raghav Bansal. I learned a lot from you, and the discussion between you and Vijay Shekhar, a lot on basic cardiac electro research. Thank you so much.
Thank you, sir.
Thank you, everyone. Thank you, everyone, for the talk. Thank you, Raghav. Thank you.
Thank you all.
Thank you, Vijay, Dr. Jahid, Dr. Prem. Thank you.
Yeah.
We wind up, Vikrant. I think we can wind up. Thank you.